Hi, this is Dr. Lamia Gabal, and I'm here today to tell you a little bit about your upcoming surgery for vaginal prolapse. And there are several different types of vaginal prolapses, and so there are also several different types of surgeries for vaginal prolapse. I'm going to describe a couple different scenarios, and this is pretty universal, though, to the type of surgery that you might be having. So about 2 weeks before the surgery, we do ask that you have a pre-op appointment with your primary care doctor. He or she will do an EKG and some blood work to make sure that your heart and lungs are healthy and that it's safe for us to put you under anesthesia. Then for 1 week before, we ask that you have no blood thinners. That means no aspirin, Motrin, Advil, Aleve. If you have a headache or anything else, Tylenol is the only thing that's okay in that week before. If you are having a rectocele repair, which means that I'm going to be repairing the pocket, which is protruding from the rectum into the vagina, then you will have a bowel prep the day before the surgery. This is necessary not to get you completely clean of any bowel contents, but to ensure that you are not constipated after the surgery, because we don't want you going into the surgery already being constipated. So it's a lighter bowel prep than a colonoscopy might be to make sure that you're mostly cleaned out before the surgery. And then nothing to eat or drink after midnight the night before. You will go to the main operating room at the hospital 2 hours before the scheduled time. I will see you before you go to sleep, and then the anesthesiologist will also meet you that morning in the preoperative area. You will be completely asleep under general anesthesia. Your legs are up in stirrups, and the whole surgery is done through the vagina. If I am not using a graft material for your bladder repair, and you should know this before watching this video, but if I'm not using a graft material, then all I'm doing is peeling the vaginal tissue away from the top of the vagina, find some good tissue on the sides, bring that together, and that pushes that bladder bulge back up to where it's supposed to be. If at this point I am using a graft material, then most likely I'll be using cadaver skin, which is very safe and very durable. It's been screened for many different types of organisms. And again, it's very safe, but it helps to keep your prolapse up where it needs to be for longer. And so at that point, I would put the graft material there and we tack it to these little ligaments that come down from the spine, not on the spine in the middle, but on the side, called the sacrospinous ligaments. And this really helps to support the repair in case of a severe prolapse or other risk factors that might increase your risk for recurrence if I were only to use your tissue. Now, if I'm going to do a sling, then that will be done at this time, and that is explained on a separate video, but it usually is a small mesh hammock that goes underneath the urethra that helps prevent you from leaking with movement, with coughing, laughing, and sneezing. And it's this tiny little mesh hammock that goes underneath the urethra to prevent that type of leaking. It's very safe and durable and is still the gold standard by which we compare all treatments for stress incontinence. And then if I'm doing a rectocele repair, that's the last part where I go posteriorly on the back of the vaginal wall, peel the vaginal tissue from the rectal wall, find some good tissue on the sides, bring that together, and that pushes that rectal bulge back down to where it's supposed to be. The whole surgery, if we're doing all of this, takes approximately 2 hours, sometimes less if we're not doing all the components. And then you wake up in the recovery room with a gauze packing in the vagina and a catheter draining your bladder. You're in the hospital overnight. The next morning, the catheter comes out, the packing comes out, and then you should be able to urinate and go home without the catheter. That's our goal. If you're unable to urinate that morning, then the catheter goes back in and you do go home with a catheter for 1 week. And at that point, most everyone is fine. At 1 week, 99% of my patients are having no trouble urinating at that point. And by the time you go home, then you should be eating, walking, peeing, pooping, doing all those normal things. You can walk around the house. You can walk up and down stairs. But for 6 weeks, no straining, no lifting over 20 pounds, and then nothing in the vagina for 6 weeks. Normally, we send you home with pain medicine, and you will likely need the pain meds for at least 5 days or so. It is kind of tough to sit with. If I'm doing a rectocele repair, there are sutures, there are stitches in the area between the vagina and the anus. So much like if you'd had an episiotomy, it is tough to sit for those first 5 days or so. So you can plan on needing those pain medicines. You can drive once you're no longer taking those pain meds. And as long as you're taking the pain meds, and sometimes even longer, we will have you taking stool softeners, because the pain meds can be very constipating and we don't want you straining to have a bowel movement. And then antibiotics for 1 week to help prevent any type of an infection. But then that should be it in terms of antibiotics. Most of my patients feel back to normal after about 2 weeks. And so if you have a job where you need to be back at work, if they can't be without you, if you can't be without them, then we usually ask that you take about 2 weeks off of work and plan to go back to work light duty without any heavy lifting after the 2 weeks. But if you can be out of work for 6 weeks, then we can write you out for the full 6 weeks, because that is when all your restrictions will likely be released, is at 6 weeks. And then you can expect to come back at 2 weeks to have a brief pelvic exam by my assistant in order to make sure things are healing okay. And then you'd see me back at 6 weeks to do a more thorough pelvic exam. And that's when I give you my blessing to go back to all your normal activities. And then what are the risks with this? Because everything in life is risks and benefits, whether that's driving a car, taking a Tylenol, having a surgery, not having a surgery. There are risks and there are benefits. So the risks, there's a small risk for bleeding. You will not require blood transfusion. You should not. But you will see blood spotting for a few weeks from the vagina. So you will need some pads for that. We usually make sure that you're prepared for that. As I mentioned earlier, there is a risk that you are unable to urinate within the first 24 hours after surgery. So then we send you home with a catheter. And then there is a risk in some cases that your leakage might get worse, especially if we don't do a sling, because there's a small percentage of women who, despite all of our testing and best efforts, we try to predict whether or not you need a sling at the time of surgery, but there is a small percentage of women who still will develop leakage with coughing, laughing, and sneezing that is unmasked during the surgery. It's not that it's caused by the surgery, it's just that when we unkink the urethra, now you may start having that type of leaking that then can be fixed with either some office procedures or a shorter outpatient surgery. And in many cases, though, your leakage improves, your urgency and frequency improves. The benefits are your insides are back on your inside where they need to be, and you're able to empty your bladder and your bowels better and easier. And this treatment generally helps with urinary incontinence, fecal incontinence, urinary tract infections, as well as the sensation of bulge and pressure. So for most of my patients, if I've made the recommendation of surgery for you, I definitely believe that the benefits far outweigh the risks. There's also a risk for recurrence, as with anything in life. If you have a facelift or anything else, everything sags again. Unfortunately, there's no way to prevent that, short of standing on your head. And so there is a risk for recurrence. Again, our goal is for this to last hopefully 10 to 15 years or longer, but there is a risk that it can recur sooner as opposed to later and may need to be redone again in your lifetime. So that is it in regards to your prolapse surgery. And if there's any other questions, I'm happy to answer them for you in real life, in person. Thanks so much.